pap smear showing LSIL. What is LSIL? Low-grade squamous intraepithelial lesion. This is a cytological diagnosis. It is not a histologic diagnosis. This is done by examining the morphology of the cell, which is scraped off. Her last pap smear a year ago was negative. She's been on combination oral contraceptive pills for 6 years. Pelvic exam is normal. Basically, the issue here is, what do you do with a pap smear that shows LSIL? Cervical dysplasia presentation. Typically, there are no symptoms. The patient doesn't know it's there. You can't even see it typically when you look with a naked eye. Most cervical dysplasia regresses. 90% will regress. Only a few will progress to cancer. How long does it take for that to happen? If it's going to happen, it's usually very slow and 10 years, which really sets it up very nicely for screening and for then intervention to prevent the cancer from developing. Now, what is it that makes the difference in the lesions which regress versus those that become cancer? It is typically a response to human papillomavirus, the natural history. 65% will regress spontaneously. This is in the non-pregnant patient. In the pregnant patient, this can go as high as 75%. 20% remain the same. They don't get worse, but then don't go away. And only 15% progress to get worse. And what makes the difference? It is the HPV typing. The HPV DNA types 6 and 11 are typically benign and no malignant potential. Those that are 16, 18, 31, 33 are the HPV types which are more worrisome and which could progress on to cervical cancer. So the low-risk types, 6 and 11, 16, 18, and the 30s are the high-risk ones. And when you look at the condyloma acuminata, these are gross, widespread lesions. These will not become cancer, although they look as if they're pretty bad looking. This is typically the benign 6 and 11 types. This is seen more commonly in women who are immunosuppressed or who have AIDS. This looks at the HPV type that causes cervical cancer. You can see squamous cell carcinoma is mostly 16. This is the exocervix. The adenocarcinoma of the endocervical canal is typically 18, but you can see the most common cervical cancer is squamous, with adenocarcinoma being markedly less common. You can see on HPV, the high-risk HPV by age group, and you can see that we have young people, less than 30 years of age, have almost 2/3 of cases. And yet a lot of these will spontaneously regress on their own. And this shows you the patients. These were young women, college-age students, who had low-grade squamous intraepithelial lesion. And this was a cytologic diagnosis. They were not biopsied. They were not treated. They were just followed conservatively. And what happened? After 1 year, almost 2/3 had spontaneously regressed. After 3 years, over 90% had gone away on their own. And this has implications then of what we should do in terms of initiating pap smears. If within 3 years, 90% of HPV has disappeared, why should we even look for it before 3 years? And that's why we don't start pap smears until age 21 or 3 years after the onset of sexual activity. Risk factors for cervical dysplasia. Early age of intercourse. Now, what would be considered early age? Well, what's the ideal age for childbearing? If you look in terms of the spontaneous abortion rate, the percentage of aneuploidy, preterm birth, fertility rate, 18 to 24 is your lowest problems. So 18 would certainly not be early. 17, probably not. I would say 16, 15, earlier than that would be an early age of intercourse. And there's something about the immature T-zone which makes it more at risk for cancer. Multiple sexual partners, you have more chance of being exposed to the high-risk HPV types. Cigarette smoking, we don't know, because I don't know of any good thing about cigarette smoking, and it certainly increases the risk of cervical dysplasia and cancer. And immunosuppression, women who have kidney transplants, who have immunosuppression for lupus, would be at higher risk. This looks at the risk of HPV infection and the number of lifetime sexual partners. You can see clearly the more sexual partners you've had, the higher is the risk. So this is a risk for cervical cancer. Screening for cervical dysplasia. The screening is done using a pap smear. And this is Dr. George Papanicolaou. This is a slide which was done in honor of him, the 50th anniversary of his describing the role of vaginal smears in the detection of early cervical cancer. And it used to be that 500,000 women around the world would die each year from cervical cancer. So we owe a lot to Dr. Papanicolaou, who was a Greek gynecologist, practiced in New York. The cervical pap test is the most effective cancer screening test in medical history, which is remarkable. It has reduced by 70 to 80% their death rate from cervical cancer. The only test that has done that well. And you can see here what's happened to cervical cancer over the last 60 years. Significant decrease. And that's because of the Papanicolaou test. All right, the pap test is a cytological screening of the transformation zone. And we talked about this earlier, the T-zone. There is a movement of the old squamous-columnar junction to make a new squamous-columnar junction through the process of metaplasia when the adolescent's cervix is exposed to the acidic pH of the vagina. And this area here is changed from columnar epithelium to stratified squamous. The new squamous-columnar junction is here, and this area is known as the T-zone. Why is that important? Because 95% of cervical cancer and dysplasia arises in the T-zone. We take two specimens. We take an exocervical specimen with a spatula. We take an endocervical specimen with a brush, non-pregnant, and with a Q-tip if she's pregnant. We smear it onto a glass slide if we do the conventional pap smear. And we fix it in formalin. The trouble is a lot of the abnormal cells get thrown away. Pap smear is not a single layer of cells, and it's harder to read. So we now then are doing a lot more of the thin layer, liquid-based, where we rinse the specimen into a preserving solution. We get it to precipitate down evenly onto the glass slide, and then you can get less loss of the specimen and a better looking smear. This is a liquid-based pap smear. The advantages: a monolayer of cells, air drying eliminated, and we can do HPV DNA typing if we have an ascus. The recommendations currently by the American Cancer Society and the United States Preventive Services Task Force is initiate pap smear screening 3 years after the first sexual activity, or age 21, whichever comes first. Repeat pap smears annually until age 30, and then every 2 to 3 years if there are 3 normals. And the reason for the change from 18 to 21 and the change from onset of sexual activity to 3 years after onset of sexual activity is because if we do develop a lesion, most grade squamous intraepithelial lesion, the regression rate is extremely high. And we just looked at that. 2/3 are gone in 1 year and over 90% in 3 years. So don't even chase it, because that means you're going to do more colposcopies, more biopsies, more cryos, more lesions. sweeps, more cone biopsies, at the risk then of cervical stenosis and cervical insufficiency. So, American Cancer Society, start Pap test by age 21 and at age 70 if she hasn't had it by then. Women over 30, every 2 to 3 years if she has 3 normal tests. Okay, Pap smear classification. This is the Bethesda 3 classification from 2001. And what we do is look at negative for intraepithelial lesion or cancer. And these are what the cells look like. Small, pycnotic, normal-looking nuclei. Then we have ASCUS, atypical squamous cells of uncertain or unknown significance. ASC-H, atypical squamous cells, cannot rule out high-grade lesion. Low-grade squamous intraepithelial lesion, LSIL. High-grade squamous intraepithelial lesion. And then cancer. These are your large basal cells which are shed off the surface with HSIL. Remember, this is not a diagnosis, this is a screening test. The diagnosis requires a biopsy. This looks at, on the top, histology. CIN1, CIN2, CIN3, SIN1, SIN2, SIN3. On the bottom here, we have the cytology, or the Pap smear. Low-grade SIL, high-grade SIL. And when you look at these, the degree of involvement of the basal cells is going to be parallel between LSIL, HSIL, and SIN1, 2, 3. In other words, if the Pap smear shows low-grade SIL, LSIL, what would we expect on the biopsy, SIN1? If the Pap smear reads HSIL, we would expect on the biopsy to see SIN2 or 3. That would be the equivalent, and we would expect them to be parallel. LSIL, SIN1, HSIL, SIN2 or 3. Cancer, we would expect on the biopsy to show cancer. So when we do our Pap smears and we do the biopsies, we want to see that they are parallel and that they are appropriate. All right, let's look at what is CIN. CIN says cervical intraepithelial lesion. Here we have the epithelium. These are the basal cells, which are normal. These are the more mature stratified squamous cells. This is our basement membrane, and below that is the stroma. As we start our continuum of dysplasia, what happens is these basal cells start to proliferate. And here we have about a third of the thickness involvement, that is SIN1 or mild dysplasia. As we progress and we get more involvement, when it's 50%, we call this SIN2 or moderate dysplasia. As we get almost the entire thickness, we call this SIN3 severe dysplasia. But it's difficult to make a distinction between severe dysplasia and carcinoma in situ, so even full thickness is called SIN3. So we have SIN1, mild dysplasia, SIN2, moderate dysplasia, SIN3 is either severe dysplasia or carcinoma in situ. Now what if things get worse? What's the next thing that's going to happen? These basal cells are going to start breaking through the basement membrane, going down into the stroma, and now we have invasive carcinoma. Remember, there are no vessels, no blood vessels in the epithelium. So as long as it is intraepithelial, there is no risk of metastasis. It's only when they go through the basement membrane. And how do you make that diagnosis? Biopsy. It's going to be a biopsy. See, your Pap smear will take the cells which are shed off from the surface only. But you must do a biopsy in order to tell, is it SIN or is it invasive cancer? And if it is invasive cancer, how deep has invasion gone? Less than 3 millimeters, 3 to 5 millimeters, or over 5 millimeters? can see is carcinoma in situ, full thickness, but the basement membrane is intact, stroma, no invasion. Now look here. Here you can see the basement membrane looks intact, but how about here? This is a tongue of cancer which is broken through the basement membrane. This is micro-invasive cancer. How about this one? Big chunks of invasive, frank invasive squamous cell carcinoma, which is going down into the stroma. And this is all assessed by biopsy. All right, let's start with the least severe of the Bethesda 3 classification. The normal, of course, is no intraepithelial lesion or cancer. As we move on, we get ascus, atypical squamous cells, uncertain significance. 35-year-old patient referred to the gynecologist with a pap smear of ascus. Our last pap smear was normal, sexually active, using OCPs. Basically, what do you do with an ascus? Definition. Atypical squamous cells, I don't know what they mean. Uncertain significance. How often should we see this? We should see it in less than 5% of pap smears, but we may see it up to 20%. What's the most common reason pathologists are sued? Failure to make a diagnosis of cancer. So if they're not sure, what are they going to put down? Ascus. 2 ways we can decrease the rate of ascus pap smears. One is to do the liquid-based or thin prep. Pap smear cells are dispersed in the liquid, and they are more evenly over the slide surface. We looked at that, and so you can see the cytology much better, and so you can have more confidence in what you're seeing. The other possibility is to do on the residual cells HPV DNA testing. And only those who have the high risk, 16, 18, and the 30s, would be follow-up. If it's 6 and 11, no need. So, here's our management scheme. Pap smear shows ascus on our thin prep, liquid-based. What do? Let's do the HPV DNA typing. If it is high risk for cancer, HPV DNA typing, which is 16, 18, and the 30s, then we would do colposcopy and biopsies. But an entirely reasonable approach with ascus is if there's low risk for a cancer, HPV DNA typing 6 and 11, just routine follow-up in 1 year. Thin prep, liquid-based. And HPV can be very helpful in this situation. Notice the sensitivity for detecting HSIL. Conventional pap smear 50%, liquid-based thin prep 80%, but if you do HPV DNA typing, 100%. Excellent. And we should be using this more. Okay, we finished talking about ascus and how we can decrease the rate of ascus by using the liquid-based pap smears and HPV DNA typing. Let's go then beyond ascus now and look at our diagnostic approach. And this is in your notes. We can look at assessment of the pap smears 3 ways. Either an accelerated pap smear, which is to repeat it in 6 months, or we could do HPV DNA typing, which we just talked about, or colposcopy. And what you need to know is this. If it is ask us, atypical squamous cell of uncertain significance, you could do either accelerated pap smear, HPV DNA typing, or colposcopy. And they will not ask you on the exam which is better, because any of these is appropriate. There has been no data to show that one is better than the other. But if you have anything other than ascus, atypical squamous cells, cannot rule out high-grade lesion, ASC-H, LSIL, HSIL, or cancer, you must do colposcopy. You must do colposcopy. So that you need to know for the exam. This is a really important point. Okay, now that we've established colposcopy, and you could do colposcopy on Ask Us too, if you have an unreliable patient that you may not be able to see again. Colposcopy is where we put acetic acid on the exocervix for 1 minute, examine the transformation zone and endocervical canal. We talked briefly about colposcope, binocular, short focal length scope, which shines a light into the vagina, and we inspect the exocervix and the endocervical canal. We want to know a number of things. One, can we see the entire transformation zone, and there is no lesion or epithelium that goes across into the endocervical canal? If that's the case, we call this a satisfactory colposcopy. If a lesion, not a lesion, if the squamous epithelium, the metaplastic epithelium, goes into the canal, we don't know how deep that goes, and we will call this an unsatisfactory colposcopy. This is where the metaplastic epithelium, which is normal appearing, goes into the canal. So this is a satisfactory or adequate colposcopy. This is unsatisfactory. And you can see how this area of epithelium goes into the endocervical canal. That's called unsatisfactory. Okay, what do we do then? We will do an endocervical curettage if the transformation zone or the squamous epithelium goes into the canal. Now, we typically don't do this routinely in pregnancy, but you certainly would do it if you have the stratified squamous epithelium goes into the canal. Okay, the endocervical curettage looks like this. You take this curette, which has a sharp tip, you go in and out through the endocervical canal, and you send this specimen separately to the pathologist. Now, it's not a cone biopsy, it's just a scraping. But since you can't do a pap smear really well in the endocervical canal, we just do the curettage. Now for the ectocervical biopsy. 4 criteria for biopsy. If on the exo or ectocervix we see mosaicism, I'll show you a picture of that. If you see punctation, if you see white epithelium, if you see abnormal vessels, those are the areas you want to biopsy. And this is my cartoonish drawing. White epithelium, punctation, mosaicism, and abnormal epithelium. Notice the canal, you can see clearly around it. So it is a satisfactory colposcopy, but there is on the transformation zone abnormal epithelium. Here we see white epithelium. This is mosaicism. This is punctation. And this is actually a little condyloma. Notice how clearly the normal epithelium and the white epithelium is demarcated on this patient. Large area of the exocervix. Here's mosaicism. And this is the Schiller solution, which highlights the areas which have different uptake of glycogen. White epithelium. You can see the patches over the cervix. Now this is grossly invasive cervical cancer. You can see this is a fungating lesion of the anterior cervical lip. And this one is even worse, deleted. You need to biopsy it. Here's abnormal vessels. You can see some of these vessels are very tiny, very small. And some of them, like this one over here, are really quite thick. The larger the vessels, the more concerned you are. This turned out to be frankly invasive cervical cancer. All right, exocervical biopsy. How do you do it? You have this biopsy instrument like this. It closes down and takes a bite like this. And you do this under colposcopic guidance. And you indicate on your specimen that you send down whether this was at 11 o'clock, 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock. And you may even make a drawing of the cervix and indicate number 1 biopsy, number 2, and so on. All right, so we have looked with a colposcope. We've looked to see if it's satisfactory or unsatisfactory. We've done an endocervical curettage if we need to. We have biopsied areas of white epithelium, punctation, mosaicism, or abnormal vessels. We send those off to the pathologist, and then when the results come back, we want to compare the pap smear and the biopsy. They should be parallel. We talked about that. LSIL, SIN1. HSIL, SIN2 or 3. The pap smear should not be worse than the biopsy. If the pap smear is worse than the biopsy, your only assumption is you missed the area where the abnormal pap smear cells came from. You see, LSIL should be SIN1. HSIL, SIN2 or 3. Cancer, invasive cancer. What if you do on your cytology is HSIL, but on your biopsy all you see is SIN1, mild changes? Something doesn't fit. You haven't found the area where the severely abnormal cells came from. What if you have cancer on the cytology, and yet the histology says it's intraepithelial? You missed it. Now what do you have to do? You've got to do a cone biopsy. Indications for cone biopsy: pap smear is worse than the histology. Endocervical curettage shows abnormal cells. A lesion enters the endocervical canal, or the biopsy shows microinvasive cancer. Here is a lesion, and it's white epithelium. It starts out on the ectocervix, on the transformation zone. It crosses down, goes across the columnar epithelium, and goes into the canal. That's different from the metaplastic squamous epithelium that goes into the canal. This is a clearly abnormal area that goes into the canal. And here you can see a lesion. This is the exocervix here. Here's the canal down here, and it's gone right into the canal. Now what do you do? Here you're going to do a diagnostic cone biopsy, and we're going to do a narrow but deep cone biopsy. It's going to look like this. So what we want to do is to cut through down as deep as we think it might go, and then the pathologist is going to slice this up into thin slices, will tell us how deep did the lesion go, did we have clear margins, and what is the nature of the lesion? Is it intraepithelial or is it invasive? Risks we talked about already: incompetent cervix and cervical stenosis. All right, so we've done our endocervical curettage, we've done our exocervical biopsy, we've done our cone biopsy if needed. Now we wait and get the histology back, and we're going to manage the patient according to histology. Our options are observation or do nothing, ablation, which is destruction of the epithelium, resection is where you cut it off, hysterectomy is where you take out the entire uterus and cervix. All right, and this is really important to get straight because this would be a great board questions. Our options are observation, ablation, excision, hysterectomy. Observation may be repeat the pap smear in 3 to 6 months, or it may be doing another repeat colposcopy or HPV DNA typing. Ablation, the most common form of ablation, which is destruction of the lesion, is cryotherapy. Laser is going to be more expensive, more painful, because it has to be done in an operating room. The most common way of excising a lesion, if you can, is with a leap. That's an office procedure. If you have to do a cold knife cone, that is in the operating room, that's more expensive. Hysterectomy is only if you have recurrent SIN2 or 3. In other words, you had SIN2 or 3, you try to destroy it, you try to cut it out, but it's come back, but not routinely. If it is SIN1, you have a variety of options: observation, ablation, or excision, and either one is appropriate. If it is SIN2 or 3, it must be either ablation or excision. Now what's interesting is the likelihood of progression to cervical cancer is very low in an adolescent. So some of the newer recommendations are, even if it's SIN2, on an adolescent, observation may be appropriate. But I would, at this point on the exam, state If it's sin 2 or 3, you don't observe. Either destroy it or cut it out. If it is sin 1, and remember, 2/3 will go away on their own. Observation, ablation, or excision. Percentage of sin that will spontaneously regress. Sin 1, 65%, 2/3. Sin 2, 40%. Sin 3, even sin 3, 30% will go away on their own. But this is high enough that we can say, we could watch it, or we could destroy it, or cut it out. But these two, sin 2 or 3, we better be more aggressive. Remember, these are intraepithelial lesions. We only need to remove the epithelium. We don't need to go deep into the stroma. Ablation. The most common ablation is cryotherapy. Cryotherapy means you treat it with cold. This is our cervix. This is the vagina. These are the vaginal fornices. We put our probe against the cervix, like this, and we will freeze the area, 2 to 3 minutes. This is the area that freezes. And you can see it will freeze the area which is an exocervix, but it will also freeze normal tissue. And that's one of the limitations of this. But it is a outpatient procedure done in the office. And this area that was frozen will hopefully slough off, and then we will need to follow up with pap smears every 6 months for 2 years. The most common excision procedure is a leap. A leap is loop electrosurgical excision procedure. You take an instrument like this, which has a wire loop of different sizes. We send a electric current through that, make this wire hot, and then we can cut away, excise the areas of abnormal epithelium. What is nice about this is you know it's gone, because you saw it and you took it out. With a cryo, you didn't take it out. You hope that it will slough off. Now you can send the specimen to pathology. You can see this is a shallow but wide cone biopsy. You basically take off the exocervix. There may be some heat artifact because it's a hot loop, and so you can char some of the tissue, but you still have some that you send to pathology and you know it's gone. That's the advantage of a leap. Conization, we talked about the 4 indications for conization. You can see with a knife, and it is sometimes called a cold knife as compared to a hot wire, and you can see it cuts out a cone-shaped area of tissue. This compares the leap, which is done for a exocervical lesion, and the cold knife, which is done for an endocervical lesion. Hysterectomy is only appropriate when you have recurrent sin 2 or 3. So even if you have a patient with carcinoma in site 2, who's 40 years old, who has had a tubal ligation, you do not do a hysterectomy as we did in years past.